Population Fund of the United Nations, and this was important to the development on research on nursing and also coordinated by the representation of PAHO in Brazil. So we would like to thank the partnership with all the members of this group and their institutions. It is a great honor to be able to build and develop this project with you, with this group that I just talked about. I would also like to thank all the speakers that kindly accepted to share their knowledge with us this morning. And so for you to understand the context of this project, I'm going to invite Dr. Ana Paula Cavalcante. She's an international consultant on health, human resources, and she was also a consultant for PAHO in health management from 2017 to May 2021. She developed a lot of consultancy with the PAHO in planning, monitoring, and evaluating on the Science and Technology Secretariat, and she's a doctor in international health. So I'm going to invite Dr. Ana Paula to give us a little bit of context for this project. Thank you so much. Thank you, Professor Carla Ventura. Good morning, everyone. So the workforce on nursing here in Brazil is developing a lot of products since it was established to carry out the Brazilian profile in the nursing international reports that was carried out on 2020 by the WHO. Also, we had as a partner in this profiling state with obstetricians that was also carried out by OMS, by WHO, when we had other different works to present this profession in Brazil. Considering this as a very successful opportunity, and since we know we have to understand the subsidies for all the discussions that we have through evidences, because we want to formulate human resources in health, that's why we created this project in partnership, like Carla said, with PAHO, with the goal to have a better environment, to have exchange amongst the main actors while regulating the nursing framework here in Brazil to help create politics and policies with the best evidence that we have. Our goal is to have different challenges to understand the availability and accessibility to those professionals here in Brazil. And this work was developed with three phases. In this first phase, we had a multi-method study. We went to collect information with national data and state data and regional data, and with a scope review of the literature with different databases and websites. And also we went to establish an agenda, a prior agenda with a workshop. And on a third phase, we had the analysis of the political options, why we were going to face those challenges. On in this third phase, we wanted to create this webinar. So the challenges that we were able to identify with this study was the unbalance while composing the nursing staff in Brazil. We had an asymmetry in the geodistribution in all the cities and states in Brazil. Also, we had a problem with the demand and offer of those professionals in this market, the health market, and we understood that we did not have any kind of planning for that workforce. So the last one, the last challenge about the lack of evidence, we saw what happened on the workshop on March 13 this year. And when we have to prioritize that challenge, we were able to identify intervention areas to improve our workforce, the nursing workforce here in Brazil, considering the needs of the population and also the distribution of those professionals here in Brazil. We wanted to have as possible strategical directions, the investment in governance and planning of the national workforce. And we also wanted to reinforce the information system so that we could improve the data analysis of human resources and health, and also to improve um, scientific proof in this field and to promote the space for dialogue between stakeholders. In this context, we carried out this webinar, and its goal is to discuss and also to identify successful experiences in this context, bringing experiences while we use methods and tools to help in the assessment of needs of those professionals. Also, we wanted to implement actions to improve the quality of data about information on the health market, and also actions to improve information about human resources in health. So in this webinar, we are going to see 3 experiences from Peru, Malta, and Brazil to get ready with these successful experiences. I would like to pass the floor to Dr. Julio Pedrosa. He is the coordinator of the Services and Human Capacities for Health of the PAHO, the representation from Brazil. The floor is yours, Dr. Julio. Good morning. It's an honor to be part of this process. Good morning to everyone from Malta, Peru, and Brazil.
Brasil começou processo de recuperação dos atores, dos fatos principais do Sistema Único de Saúde. Dos desafios é precisamente a falta de evidências para o planejamento da
One
força
of
de
the challenges is the lack of evidence to that workforce, but not only in this case, but nursing, as it is in Brazil and in most countries, is the main workforce in the health area. So in this context, I'm convinced that this webinar is going to have enough elements that are going to improve the discussion of the experience from different countries and the methodology that is going to be used is a methodology that is being homogenized, standardized in a way, in such a way that it can allow the countries and the health ministries to implement those actions to improve the quality and availability of that workforce. And this also is part of an improvement, an integral improvement, a whole improvement of the information systems of human resources in health. So the PAHO, the Pan American Health Organization, is very interested on these discussions and the conclusions of this webinar, and it is going to also be working and giving support to all the countries to improve work conditions and also the performance of health professionals, and finally, a better health for everyone towards universal health. Thank you so much, Dr. Julio, for your support on PAHO in this project and the possibility of this work together. And now to begin our table, I'm going to invite Dr. Bruno Guimarães, is the Director of the Managing Department in Health from the Work Secretariat of the Ministry of Health in Brazil. The floor is yours. Thank you so much for your support. Good morning, everyone. Like Carla already introduced me, I'm in the Health Ministry, and I thank you so much for the invitation to be here, collaborating with this table, coordinating all the presentations. I'm not going to take too much time because we have the expectation to see nice experiences, which is such a great subject for us. We have been going through a restructuring program here in Brazil, and this possibility to articulate and exchange experiences is a really desired place by everyone here in our market here in Brazil. So I'm going to invite the first person to speak, Dr. Eveline from Canada, for us to begin this discussion. I am Evelyn from Canada, I'm sorry. And to begin this discussion, you're going to follow the order that we have here, and then we will move forward, okay?
Que está na Escola de Estudos Sociológicos e Antropológicos da Universidade de Ottawa.
Perdão, a primeira a
I'm
apresentar
sorry, the first person to present will be Lizardo,
Perdão.
with the experience of Peru,
Tá bom. Então,
okay?
vamos lá. Então, a primeira apresentação vai ser o Dr.
Then let's go with the
Lizardo
first
Huamon.
presentation with Mr. Lizardo Huamon. Is that right?
Dr. Lizardo, por
So
favor,
Dr. Lizardo, I'm going to talk about his bio of each and every one who are going to present here. He's a surgeon, graduated by National University of San Marcos. He's an expert in health administration, and also he's an expert on human resources in health by the National School Sérgio Arouca here in Brazil. He also is experienced in the Peruvian health sector, and he's also has been working on the health ministry of his country, which is responsible responsible by all the health workforce during the pandemic of 2019, COVID-19. He's also working with many different sectors in his country with residencies and also creating residencies in the science of health, also working in different universities. And he was a visitor professor at the Andalusia School in Spain. He's a national consultant, and he has been supporting many different initiatives in the national area and also the Mercosur area with the Italian cooperation and Belgian cooperation, developing the human resources in health and strategies to have a multi-professional health system and strategic plans to the workforce. Dr. Lizardo, welcome, good morning. The floor now is yours.
Muito obrigado. Muchas gracias a todos y todas.
I want to thank you all very much. Thank you. I want to thank the Pan American Center for Research in Infirmary. I feel honored to be with you in this meeting this morning. And in fact, in a few minutes, we'll try to summarize the whole experience that we have been able to develop an experience in the last 30 years in Peru. In terms of a strategy, I will put up my slides. First, I would like to introduce to you a reality showing the map of poverty, monetary poverty in Peru. In this case, I'm showcasing the actually deep poverty that our country is immersed in. You see the map of Peru on the left-hand side of the slide. You have the different districts, and we see the rate of poverty that affects our population. And the program that we are going to be discussing today actually focuses on and try to understand the implications of human resources and it impacts. And also in our country, we have big problems in access. We have problems in access to health services as all. It's not just problem linked to the economic aspects. A big effort has been made lately in Peru. So this could be a gap that could be closed. Yes, it's still an ongoing problem, a big problem in terms of access, lack of access, because because there's scarce human resources in the field of health. I'm going to be introducing to you the whole experience of Peru.
In health, regarding serums in Peru, and it continues being part of that great wish, great goal to build public policies in order to approach in a whole approach the great and severe problems that we have in this field. So as a health system, what are the challenges that we have regarding the human resources field? The great challenge is to maintain the health at the highest possible levels. That means to decrease the rate of lost years for a healthy life. Therefore, we organize ourselves in a number of responses, and one of them can be covered by the coverage in order to reach a universal coverage. The other approach that the health system can be measured is sanitary impacts, the capacity that it has to avoid deaths, premature deaths, and diseases due to lack of good systems. Another one is the quality of care regarding the satisfaction of the users of the system. Regarding human resources, this capacity of the system is very closely connected to three issues. One of them, the three gaps that we have to cover in the strategic research. One of them is exactly the access of the population to multidisciplinary teams that are wherever they are needed, and that these teams have to have the competencies to approach and hold the approach all the community and the families that are involved, and capacity to manage all the public health requirements. And lastly, there's a great effort of the institution to develop in order to improve the jobs and work in order to withhold the human resources wherever they are needed. So Serum is a program that was launched based on another one that wasn't quite well established. It was called CECIGRA, that used to establish that the medicine students in their last year, they should go to the poor zones of the country. And there was a great discussion in the 70s, more or less, that made it into a program of the state. So it's a program that is aimed to professionals that are recently graduating in medicine. There are 14 careers that we have in medicine, and it's the requirements that they have to be hired by the state in any kind of contract, or in the case, above all, of physicians that want to specialize themselves, they should then have followed this program. However, summarizing this process, it's exactly that it's a program that has had a flaw in their mission. And we have shown this map of Peru regarding poverty. So we have specific colors regarding to the variable of poverty. In 2006, we had the first effort to map where are these kind of professions. This program since 1981, and only in 2006 we started to have a system that could inform us where are these professionals. And we start to design a backbone in the countries that continues exactly the distribution of poverty. In 2008, that is the last map, unfortunately, that we have regarding this approach, because we're a country that has a lot of discontinuities. And in this sense, we have a much better map. However, what we would like to show you, the analysis of the study between 2006 and 2008, what happened during this period. In first place, we have a diagnosis of the main problems, and we established that this service doesn't comply with the objective that it was launched for, because unfortunately, during some decades, we have, while the population poverty increased, the programs were maintained in a very low number of people involved, and of course, with a very lack of professionals. The distribution, in spite of this program had been launched for unattended zones, we will see now on the screen how, in fact, it really was. So we had an important number of people, participants, and there was a lower amount of people, vacancies, and we had also a lack of efficiency. We had a lot of people involved, but we didn't have the vacancies. And this was due to many reasons. The first, based on the Washington Consensus in our country, we had to hire health professionals. That was not well accepted, and the pandemic really broke in a way this approach. But in 27H, as we can see, we had a participation in this. We had a lack of funding also to cover all these vacancies that were required, and also the distribution in our country. It had to be with, we had to have the participation of the health ministry, and we didn't follow this program as it should be. So it was only based on the requirements of different players that really didn't have anything to do with the poor population, and lack of agreement with different players that had to do with the distribution of human resources. And in terms of management, we had a bureaucratic management and a lack of sanitary authorities that effectively we didn't have a strategic and the results. This is a sample where in one specific year, we had more than 15,000 applicants. There were about 7,000 vacancies, and of these 7,000 vacancies in the case of medicine, for example, we have 307 vacancies. So this is very severe in a country where these resources are so important. And on the other hand, you can see that in 2006, this program had ensured to be in poor zones. 48% of these population didn't count with serums in the year 2006. So we started a process that was quite interesting, in spite of all the frustration and trying to change things. And based on this, we regarded that the main goal was that this program that was not complying with its goal would be followed. So for this, you can see here on the screen. However, in order, no, here it is, I'm sorry. So we needed to have a positive availability of human resources in unattended zones. We have to continue the offer of vacancies at once and to distribute in the poor zones and to have a greater effectiveness and efficiency in the application of these vacancies. And then we established strategies to increase the funding through an effective funding source. And we gave a lot of value to the management of this, and we started to obtain agreements with the decentralized levels of these professionals. Regarding bureaucratic management, we went to strategic observation of the country in the long term. And of course, considering this, we held a specific body, the highest level of body, in charge of this program. So, among others, in terms of specific requirements, we established also a number of strategic actions where we started strategies in specific moments, and we have some difficulty sometimes. And I'm only going to mention two examples because of lack of time. For example, regarding the strengthening of the management, we designed an alternative program of serums because serums have a lot of programs and it's established by law, and it's only 1 year of a period. And we wanted one for 3 years, and it's only available for a number of people. And we wanted this to enable a multidisciplinary group to be in different working lines. And also, it's the same to be near the near and last zones because they pay the same salary. So with these alternative programs, we would like to have differences, have bonus in order to make the program more attractive to the physicians. But it wasn't able to attain this because we started to sell to be in charge of the poor zones that funded the poor families to give an amount of money and to show that this was very important for them. But the greatest problem in the poor zones that we didn't have human resources. So we understood that this program would replace and could offer also this advantage to obtain the objectives. Therefore, as we didn't have any law approved, this funding was not able to be obtained because it had been already offered. So we went to Serum program, and this program was the first effort that we held in order to block the financial restriction for the hiring of human resources. Another of the issues that we held also was that we gave importance to the medical residence. And in this sense, in the past, it didn't have any importance at all. Of 100 points, they used to have 9 points in order to participate in medical residence. Then we established that the amount should be of 10 points of 100. And this brought a much higher bonus to the physicians, and a progressive increase with a very high leap in 2007 of new vacancies. So from 2005 backwards, it was a number of vacancies that was established, let's say, as you can see on the screen, and from 2006 to 2017, this increased quite a lot, as you can see on the screen, due to the funding that was embedded in this new program. Not only this, but also you can remember the previous screen when I used to show the 52% that were in the extreme poverty zone. We went to 79% in 2007 and to 81% of extreme poor zones in 2008. So this was a result of the strategies that were established. In order to optimize this program, we have seen also between 2008 and 2010, how of the offered vacancies, we had a gap that in 2010, we reached the end of these gaps. Unfortunately, we had some problems with this, but the comparative advantage we used to have in average of 1,000 vacancies in 2007 to have more than 9,000 vacancies offered in the system. So in terms of what does this result of initial impacts? This is a province. This is one of the departments of our country. And it's a district. And you can see the availability of physicians for each 10,000 group of inhabitants. And in red, you said that less than 10,000 inhabitants, so we don't put the serum program. If we apply the serum program, we have the green color, and you can see a great improvement in the possibility of these professionals to be able to work in this region. This is much better distributed and has been proven. And the important thing is that we have made a follow-up and we have proved how this improvement of the availability of human resources has decreased the mortality of mothers in these places where the greatest availability of human resources was practically in poor zones, thanks to this program. Which are the lessons learned? I'm sorry if I'm overcoming my allotted time, but is it possible to do things in a different way? There's not, the worst management is the one that is not done. And in the case of Peru, I could mention, you have to do the management, we have to be prepared, we have to insist, because at some specific moment, if we have some offer, we were able to have the possibility in order to be able to apply all our knowledge. And the great transformation objective to transform this program to a whole program in human resources that considers not only the participation, but also helps a multidisciplinary group and improve the working conditions and jobs of our workers, with the mission of building in a progressive way a health system based on PAHO that should consider the first element. Now, we required also that the strategy is transformed in a public policy. Therefore, this is what I would like to show you very briefly regarding this program that is still having some kind of gaps. Thank you very much.
Thank you, Dr. Lizardo, for your presentation. I think you have brought us important elements that will contribute to our discussion so we can look at this planning of the workforce based on the experiences of different agents and actors. Perhaps, hopefully, this exchange of ideas will allow countries that have so many bottlenecks that will allow these countries to build a possibility so we may have a sufficient number of workers, male and female workers, in places above all where there is a historic difficulty in supplying workers and having strategies for the attraction and retention of these workers. We're now going to give the floor to the second speaker, the second presentation from Malta by Dr. Maureen, the Ministry of Health of Malta. We're going to be talking about the trajectory of Maureen Hope. Currently, she is the General Director and she is in charge of human resources at the Ministry of Health of Malta. She's been working over the past 27 years in many activities for the Ministry of Health of Malta. Recently, she led a multidisciplinary team in drafting a strategy for the health workforce titled supporting and providing capacity building to the health service labor force, launched in October last year. Currently, she's leading the implementation as part of the national strategy of health in Malta. Miss Maureen, you have the floor now. It's a pleasure having you here with us, sharing your experience with us. And now you have the floor, Ms. Mahoney.
Thank you very much. It is my pleasure to be here. Thank you for inviting me. It's a pleasure to be in your country, virtually at least. I'm not sure whether you're seeing my presentation. Can you see my presentation?
Conseguimos ver sim. Conseguimos, tá?
Yes, we can, Miss Maureen. Go ahead, please.
Okay. Thank you very much. So as As you said in the introduction, I
Colocar
have,
full screen.
sorry,
Desculpe, Maureen, ela tá a
Sorry,
apresentação.
Maureen. The presentation is too small on the screen. We'll see if we
okay.
can enlarge it so everybody can see it in detail. Thank you.
رجع لي بحال الأول كيف هنعمل؟
Não mudamos ainda.
We haven't changed it yet, Ms. Mahoney.
Penso que é pela divisão de tela, se
It's
tiver
the division of the screen. If you have to have split screens, and she's dividing it, you're dividing it in the opposite way. Oh, now it's much bigger. Yes, go ahead, ma'am. Go
Okay,
ahead,
better
Ms.
now?
Mahoney. Go ahead.
Okay.
Vai.
So as you said in your introduction, basically last November, I was tasked by the Ministry for Health in Malta to draft a new health workforce strategy for the ministry, which we are now slowly implementing. Basically, just to give you a background, Malta's healthcare system depends mainly on the government provision of healthcare. So it is mainly a public healthcare system. There is a minor private sector contribution to healthcare in Malta, and there are a few private clinics and a couple of private hospitals, but mainly the healthcare system depends on the public health system. HR planning is conducted by this office, basically by the Human Resources Office within the Ministry for Health, in collaboration with the ministry responsible for elderly, because the elderly care here in Malta is a separate ministry to that for health. What are we doing currently? So currently, before this system is being introduced, we are duty bound to provide a 3-year human resource plan to central government, which is reviewable annually. So basically what we do is that we consult with our respective hospital CEOs and the heads responsible for the various services, and we collate the resourcing required for the coming 3 years and then review on an annual basis. And we provide that plan to the central government. Central government is responsible for collating the HR requirements for 3 years across all ministries within the public service, basically. So last November, we launched a national health workforce strategy as part of the national health strategy. And the strategy covers the period 2022 to 2030. So basically we are planning for the next 8 years. It includes actions which are related to health workforce planning mainly, but also to issues related to employee well-being, to data, to methods of retention of staff, to closer collaboration with our educational institutions, among other issues. So we are working on all these issues concurrently. We have worked very closely, collaborated very closely with the World Health Organization, and we have a consultant whom we are working with and with whom we have developed a health workforce planning tool, which will obviously assist us to plan better. So identify the gaps between supply and demand. And the tool takes into consideration a number of issues and can also be used for multiple workforce groups. So we can decide to plan for nurses, or we can decide to plan for nurses in a particular setting, primary health or acute care. The tool helps us with providing a longer term and a more evidence-based HR planning. So basically, currently we are planning for 3 years, and that is not sufficient because obviously training for especially specialists and certain areas takes more than 3 years. So basically we need to start planning earlier in order to be able to have the supply we actually need. Currently we are piloting the tool in collaboration with WHO, we have started working with general practitioners in primary health. And this has already shown us, the tool has already shown us that over the next 20 years, we would need to increase the supply of general practitioners. Basically, Malta currently is going through big demographic changes. We have practically doubled our population in a few years, given the fact that we have a big influx of foreigners. So basically that will have an impact on provision of healthcare. Lessons being learned in the process. So basically it is of utmost importance to involve all stakeholders in our HR planning process. It is not enough for us to plan on our own. One of our major stakeholders is obviously the Ministry for Finance. So we need to have the adequate financial backing in order to be able to fill in the gaps which are identified through our planning process. Another one of our major stakeholders are the educational institutions. So basically we need to work closer with the University of Malta and with all those education institutions who basically supply us with our health workers, health professionals. Data is something which we are working on very, very eagerly, because without data, it is obviously very difficult to be able to plan. So having available data and accurate data is of utmost importance in order to plan better. Obviously, we need to have regular reviews of our plans, transparency and accountability. In our opinion, that is very important in order to be able to implement the health planning, which we actually do. Obviously, like everything else, we are expecting to find resistance to change. So if we have till now been planning short term, in order to be able to plan long term, we are expecting some resistance at least to change the way we actually work. Data sharing, we are finding a bit of challenges when we come to acquire data from certain entities, especially though those which we have no authority over, those bodies which are independent, like the professional councils, for example. We do not have, as a ministry, we do not have direct access to the data held by the professional councils, and also to the resources available in the private sector. We do not have visibility of what the private sector is actually employing. We work in a highly unionized environment. So basically, most of our healthcare categories are represented by a union, and convincing these is one of our major challenges. The unions are very vociferous, have a lot of power in relation to the way we work. So basically, being able to communicate and show them the way we are working is of utmost importance, and basically bringing them on board with our plans. And obviously budget is another challenge. We need to work within whatever budget our ministry is given through the Ministry for Finance. However, we are confident that if we have all the stakeholders on board, we will manage to achieve all the issues that are outlined within the strategy itself. Thank you.
Obrigado, doutora Maureen.
Thank you, Dr. Maureen. I think your presentation gives us nice elements that can collaborate with the discussion, also articulating with the educational institutions and how to articulate data so that we can have better decision making. Also, when we have the unions, it's nice to be able to work with the unions, to be able to dialogue so that we don't have as many tensions and conflicts. And finally, the budget and all the financial part that is so important to any kind of change for the workforce. So these elements, also with the elements that Dr. Lizardo brought us, are going to collaborate for our discussion after the presentations. So many nice presentations. Thank you so much for your presentation. Now I'm going to pass the floor to Professor Betty Lelo. She's from Brazil, and she is going to Dr. Elizabeth Nascimento Lelo. We call her Betty Lelo, but I'm going to talk about her bio and her experiences in this subject. So Betty is a nurse, she's a specialist on public health. She's a doctor in collective health. Also, she's a coordinator of the workforce and health of the Brazilian ministry, health ministry here in Brazil. And she has a huge experience in the discussion of workforce planning, especially thinking about the first assistance in health. Welcome, Elizabeth. It's very nice to be here with you. And now the floor is yours for you to make your presentation. Thank you so much, Bruno. I thank you so much in the name of Dr. Duran for this invitation. It's so nice to be here in this group today to bring this discussion to the health system, especially when we are going to manage our work. So thank you so much. I hope I can contribute so that you can see everything that we can advance when we want to plan our workforce. I'm not able to pass the slides. Now you can see it? Yes, we can see it. Thank you. So here in Brazil, the health system model is the SUS, which was implemented on 1988 from the Brazilian Constitution. Firstly, it was organized by the healthcare systems here in Brazil, the networks, and they are organized here in Brazil on the second attention here in Brazil. I'm going to talk about the basic assistance, where the methodology, where I'm going to show you our experience, is anchored in this objective. So the basic assistance is the main entrance for all the users here in Brazil. It's a communication center between all these levels of assistance, secondary or tertiary. We coordinate all the users and the services that are available in this network. It should be in an adequate timing to assist all these users that come through the primary attention that here in Brazil is 88% of all actions that are going to be available to our population. So this assistance axis is a policy that's regulated by the 2.436 law that has its last review on September 2017. And its strategy is the family health to afterwards expand and consolidate the basic assistance. This strategy is working here since 1994. We had a few changes, but this is the main axis so that we can give this basic attention to our users. So regarding planning of our workforce here in Brazil, the health ministry, working with the PAHO and the WHO, they asked us to make a study to understand what was being done by all the markets regarding this subject here in Brazil. So we had an integrative review from 2010 to 2020, where we were able to find many different publications. We found 113 papers. All that literature we were able to find on Google Academy. And all the main actors that were involved are the public universities, and here highlighting USB, which is the University of São Paulo, and the University of Rio de Janeiro. And I was able to take a look into it with a professor that's here with us. And he, along with another professor, are the ones who are responsible for producing everything in that university in Rio de Janeiro, the Ministry of Health, the PAHO, and the WHO, hospitals, mainly public hospitals, but we also have a few private hospitals. We have human resources entities, state secretariats, a few institutes and private universities, and a few other actors from 2010 to 2020. So the Ministry of Health, along with the PAHO, was concerned at the time with what was going on with our health system regarding planning and dimensioning. And then they launched the award InovaSUS. At that point in time, I had the opportunity here in Campinas. We were already developing a methodology to this primary care, and we participated of this award, and we were awarded with the second place when we brought the proposal of having a primary care methodology. Even from that point, the Ministry of Health, along with PAHO, had many different actions and activities to implement that methodology in cities in different regions here in our country. And most recently now, with Director Bruno that's here with us, his department had a planning through the creation of a coordination of planning of that workforce here in the SUS in Brazil. So now the Ministry of Health has a specific area, a specific team. I'm a part of it to think, organize, and plan all the workforce here. So the methodology that I'm going to present you is this one. And right now it is being digitalized by the Ministry of Health so it could have, so that the managers of our country can have more access. We have over 5,000 cities so that everyone can have a quicker access to that methodology and can be able to implement this tool with its own territory. So this methodology, like I said, it was developed here in Campinas when I was a manager of this department here. At that point in time, we did not have a methodology for this level of attention. And along with our colleagues, we had a multidisciplinary team, and we started to think about this possibility to have a methodology that would be specific to primary care. At that point in time, based on the PNAP that we had from 2001, where we have a few parameters, guiding parameters, we were able to elaborate this methodology. And it's anchored in 4 guiding questions. To whom? So we identified the territories, we considered the dynamic territories that are part of the areas of each health unit. Where are those users when they deal with the daily conflicts of those territories and the health needs that are singular for each population? So that's the first stage for the guiding questions. And then what? So we work to answer that question from the actions and services that are offered to all the users. So what are going to be the activities that those professionals are going to develop to meet the demands from the users in terms of primary care? How, which is the work process, how those teams are organizing their processes, how are they establishing their flows, so that they can meet the demands in a very keen way to help all the users. I always say that in this moment is the more complex work, because here we are going to take a look into how those workers, how the workforce is organizing themselves. Sometimes we have a shortage or superavit, and we have to change. We know that this is not simple. We need to make a huge effort from those hospitals, from those communities, so that we are able to be more keen and more evolving. And finally, how many? In this phase of the method is when we have to have mathematic calculum, using all the data that we have to the moment in a way that we can make analysis, comparative analysis in our existing workforce and what we need to be able to meet the demand of all the users in that unit. So the first stage of the methodology, like I said, answering to whom, we are going to identify the total population of the city. Here in Brazil, we use data that are submitted by the IBGE. But if some city has a parallel information that's different and that maybe is more than is being informed with the projections of IBGE, since they give us this information from 10 to 10 years, many times those cities can use that information. We just implemented in the south of Brazil in a city where they had the information that they were able to use and amplify that population in a way that we were able not to exclude any user when we would start using the tool. The second stage is the definition on those users by health units. So we know that we have a few cities, they can be small or bigger or medium-sized cities, and they have different units. And each health center has to organize itself to meet the demands of those territories, guaranteeing access to all the users. So we have different descriptions of users per unit. When we have a city that don't have a city that doesn't have that description, we need to create that description. So this is really a huge work where we spend a lot of energy to be able to understand the territory, to understand that map, and to understand the resources to meet the demands. On the second stage, we are going to identify the social indicators that are going to be able to identify all the vulnerabilities of those territories. So here is important to understand that this data, they are not aggregated. So when the city has data that is only from the city, this is not going to be used, because we need to understand with all the units if these indicators that were chosen from the guiding lines, we need to understand what is the actual value and how this is working for each territory. This is different from one unit to another. On the third stage, we can find an average of all the units using math. After identifying that average, we are going to identify the average of the selected indicators amongst all the health units. So it's going to be amongst 30, 40, 100. We have to calculate the average value. On the next stage, we have to understand on how many levels we are going to classify. We are going to divide the health units. We had 3 different categories. When the city is bigger, the city can have 4 categories or even 5. Here in Campinas, we had the first one, we divided in 5. Low, very low, average, high, and very high. And through time, we would realize that it would be better to go to 4, and now we have 3 levels. But each city, each manager from their teams, they need to define and to see what's better to adjust and understand the needs to understand the needs of those users. So how are we going to find that information? We have to find a place between those indicators, and from the average of those indicators, and from the definition of those numbers, we are able to divide and find what is the interval that is going to be between a classification and the other one.
Afterwards, we classify it by units here in the municipality in low, average, and high in accordance with the indicators that were found and the average of these intervals that were obtained from the calculation that we did beforehand. Later on, after that, we do the definition of description of users for each classification in accordance with PNAB. It's recommended here in Brazil that we do between 2,000 and 3,500 descriptions of users. This municipality chose to do it that way. 3,500 users per team, and the high note was 2,500. The higher the vulnerability, the lower the number of users described by health family team, thereby ensuring greater access and multiplicity of services and greater effort defined between the team of health, the health plan, health family team that will be effective and enough to cater to the needs of the users. But you will see in other experiments, there might be another description that is not the one that you see on screen. So if your municipality, especially the large ones, they have a description about when there's low vulnerability above 3,500, and they get sometimes to 4,500, they have a hybrid system that's not 100% health family units. They cater to the needs of a certain territory, and there is another part of the population that's described, but they're not this definition of health family unit teams. They do differentiated, they provide differentiated assistance programs. There might be a different kind of description. When it's high, it could be lower too. It could be 1,800 people, depending on the axis and the zone of scope. You have the geographic location, which allows you to widen the description. And step number 9, we're going to divide up the number of users described in each unit that's been described, and it's going to be divided up by the description made in the previous item. I'm going to show you a table in which we're able to identify the number of health family teams that we need for each base unit. If you will pay attention here on the first line, there is a unit in this municipality where the description done for this unit was 8,745 users. The average of indicators found, which were selected for this unit, was 24. So it was classified as high, and the description of users is 2,500. So we divide up 8,500 by 2,500, we're going to get the number of teams. In this case was 3.5 teams. And you might be thinking, how are we going to organize 3.5? There's no 0.5 professional, 0.5 team. So there is a guideline here. The local manager should look at this and increase or reduce or leave it the way it is, 3.5, considering that there is some workload. And to give you an example of how it works out in practical terms, I'm going to give you an example from the nurses. What are the professional categories that are encompassed in this program? We have a multidisciplinary team where you have a medical doctor, a nurse, and a nursing assistance technician, a health community agent, a dental health team, a dentist, and ASB/TSB, pharmaceutical assistants, which is a pharmacist, and a drugstore auxiliary assistant, a pharmacy assistant, an administrative technician as well. And there might be other categories as well. It's possible based on this methodology, and we will incorporate these other professionals, actually, depending on the needs of the team per se. I told you that I was going to give you an example of how this works out in practice. I brought you an example of a nurse, since we're talking about nursing in Brazil. So this same unit, when we identified that they have 3.5 teams, we multiply it by 40 hours a week, which is the standard workload, so that we will find in terms of hours, how many hours I would have to have for each professional. In this case, under 40 hours. And the manager then, if it chooses to leave leave it at 3.5, you will have 3 family health teams certified in 20 hours of nurses, 20 hours workload of a nurse to provide assistance to that population. So we always work on the possibility of having the standard workload in order to make it easier for managers when they work out the dynamics of the hiring. It could be 40 hours, 30 hours, 20 hours. That makes it easier to have the exact hired professionals as a manager in the municipality of Campinas, especially for medical doctors. When we establish this one kind of workload, say, for example, 40 hours a week, it's hard to find these professionals and to retain them. The possibility of offering other kinds of composition helps us in and coming up with the teams and retaining these professionals in the long run. As for work processes, in this municipality, we've defined that 60% of the workload of a nurse should be geared to assistance, 20% management, and 20% education. I'm not going to go into detail about this because of the time is not on our side. We'll have the chance to debate it later on, but this is where we look at the initiatives that will be developed and based on the needs of the users and considering the attributes of each person. Each professional has his or her established attributes. At this point in time, we do this organization of work processes, and it's very interesting from a practical perspective. When as a nurse, for example, in assistance, I know that 20% of my workload is geared to a certain activity and 60% and 20%. So I'm able to plan myself and organize my workload, catering to all the activities and initiatives that are under my responsibility. It helps health professionals organize their own schedules and helps managers also to do the coordination of all of these processes together. Yet an important factor that is very important in the methodology is the potential of annual productivity potential. What happens is when we do a historical series of production, and there are some indicators to work on individual production of each profession. For example, we have found that in practice, the figures tell us that there is an overload of work and sometimes idleness. So there is a possibility of forecasting that the highest potential that we call it, we deal with it that way. In the case of nurses, with 60% of its workload would be geared to considering 2 appointments per hour. He would have 2,280 appointments in a year. That's an average. It could be a bit higher, a bit lower, but we have found figures that are very far from this average, 100 or 100. So this flow chart helps us reduce conflicts that you have within the team. And I brought you an example of the nurse, of the assistants. You have 1 professional per health family team. The net doesn't tell you exactly how many professionals. You have to have 1 technical assistant, but it's up to the manager to define how many professionals they'll be allocating to a certain team or to a unit without being actually linked to the team. In the case of this municipality, they chose to have 2 technical professionals or nursing assistants per health family planning. So you have 7 professionals, 280 80 hours. Since I told you before, these hours could be supplied upon hiring in many different ways, ensuring 40 hours for 3 or 4 teams, and the other hours could be supplied in 30 hours, 20 hours to by these professionals as well. And the organization, even though this was defined as the same thing as nurses, 60-20-20 attributes are different. So the definition of the organization of the work process is different. As for productivity potential for this professional, the average established for appointments is 4 appointments per hour, which will generate then 4,572 appointments per year. Remember that this could go up or down. That's an average we're talking about, and the average number of appointments for an hour. Many times you do 2 an hour, depending on the demand, and depending on the length of the appointment. Some appointments are shorter, others are longer. We're always working with the average. Comparative analysis here. I haven't brought you data for all the categories because the time was short for my presentation, but I can share with you later on details of all the positions that we have developed. In accordance with this methodology, you can get to know what doctors do, and dentists and pharmacists. They all have their own way of organizing their own schedule. But once we do all the professionals, we do the comparative analysis, which is the 4th question. And then we have the data defined for the municipality as a whole, a health district and basic health unit. Why is it important to showcase the outcomes? The municipal manager has to take the data as the foundation for his analyses. And the health districts look at their own territory. Managers need to know. It's as if we had a magnifying glass, how my workforce has been organized and what I have in terms of availability. And is there a deficit or a surplus? And lastly, we applied the technical safety indicator regulated by COPIN in 2017. What are the lessons learned? The most important lesson is that the construction has been collective. When I say collective, it's not only the workers that today make up the management of health and education, but together with the Department of Planning and the Financial Department and the representatives of health districts and the workers and professionals. Represented by categories: nurses, doctors, community agents, health community agents. If we don't bill it that way, we'll have the wrong dimension. And when everybody participates, there is a joint construction that everybody will understand it. And you will be able to actually do some fine tuning, and the outcomes are easy to be accepted and implemented around the whole network of services. Yet another lesson learned is that we must incorporate social controls. When you get the first outcomes, you should present them to the local council and the local health departments, so that they'll understand that they were doing a dimensioning process, not to fire anyone or to cut down on resources, but to strengthen the value of the workers. It's important the social control participates in this process, and the need to monitor continuously is important. That should be done from the point of view of hiring. On a monthly basis, we have changes, hirings and severances and leave, cases of paid leave, that has to be done on a monthly basis. And we've tried to implement that methodology. Once every 2 years, we should review the indicators that were selected, the parameters, so that they'll be able to cater to the needs of the guidelines of the municipal health department. What are the challenges? We have here the capacity building. That's a problem we must look into account. How are we going to improve and qualify and provide capacity building, hiring per se? We need, that's in the financing part is important. Not only financing, but also we need to define and organize better the hiring process and widen and strengthen the financing of primary health care. These are the references, the bibliographical references that you can have access to. Thank you so much, and I'm at your disposal, so we'll have a little debate afterwards.
Oi, Beth. Bom, muito obrigado por sua
Hello,
apresentação.
Beth. Thank you so much for your presentation. I think that you've brought important elements for our discussion insofar as you have presented a methodology that has been employed and validated, systematized, and it's in the process of being replicated and duplicated in other realities. This methodology was developed in Campinas in a specific scenario, in a specific state of the union, but there is a possibility of replicating that methodology elsewhere in other municipalities in Brazil. And it can also be customized from the perspective of being suitable to different realities that we have around the country. So thank you so much for your talk. Now we're going to be opening for Q&A.
Queira fazer algum questionamento, possa levantar a mão.
Those of you in the audience who want to ask a question or make a comment, please raise your hand and we'll be giving you the floor. But we also have questions that came on YouTube. They're being systematized for people who are on the panel with us. I would like to start now with Professor Maria Helena Maziali. She would like to ask a question, and then I will go on to the questions that are in the chat room. They were requested by the people that are participating on YouTube. Maziali, are you with us, Dr. Maziali? Thank you so much, Bruno. Good morning, everyone. I'd like to thank you for the possibility of listening to all of you. Everything you said was very interesting. As a professor and being in the academic and living in academia, actually, and working in academia, I'd like to put a question to all of you. Those of you who have fully developed plans, and those of you who have plans currently under development, what is the role of the academia? How can academia help you, and what's the intersection of the planning exercises and the ministries of education, in the sense that we educate people, we educate human resources that will be made available for these initiatives, and in relation also to the role of the production of scientific evidence as input for these actions and initiatives. Thank you so much for the chance to ask a question to all of you. Thank you. I'm going to give the floor now to, because Marilena won't be able to be with us. She will have to leave, and I'm going to give the floor now for the answer. I'll give the floor to anyone who might be able to answer that question. Marina Lizardo are also with us. Is that right? On screen. Elizabeth is with us on screen. I can see her.
Estão conseguindo me ouvir, gente?
Can you hear me, folks? The last part I got lost. I got lost in the last part. Could you repeat the last part of the question? It was about investigation.
What's the term of research?
Não, como a produção.
How can the production of knowledge and the scientific evidence, how are they helping us in the execution, the performance of these initiatives? What can we expect by way of production and the directioning of research that can be used as input for these initiatives and practices? Is that clear, guys? Is that clear? Her question, is that clear? Yes, it is. Professor Liz, Professor Lizardo, would you like to talk? In which case I'll answer later. Go ahead, Elizabeth.
Okay.
Professor Marilena,
Professor Marilena, as quickly I brought you in my presentation, the production of knowledge that has been done in the universities, it's been relevant in the sense of reordering.
So that we can take a look into the methods and also to organize the workflow in terms of health. So the planning area and dimensioning area has been brought today with a huge relevance, not only here in Brazil, but we have seen that in other countries. And the production that we have been seeing in the universities, they are very relevant. They are going to contribute very strongly. And I think it also has to do with how the capacity building here in the SUS, we can see this proximity that is being carried out. So the production also is working with the needs in a very important axis in health and education. Thank you, Elizabeth. Professor Lizardo.
Gracias. A ver, la
Let
producción
me
de
see. Production of knowledge, let's say, the most important input for strategic planning for human resources in the area of health. The role played by ministries definitely is hindered because no interaction with the university academia that dedicated to generate that knowledge, perhaps that the natural role to be played by the academia and the universities. And therefore, what has to be done is establishing these bridges, these spaces of interconnection, these spaces, these links, so that we can develop links to generate relevant information that finally would be a virtuous cycle, since the planner will have proper information that can apply in terms of evidence. Is different to plan a trip without knowing what's your destiny than doing it with the necessary knowledge base. Also, it's a virtuous cycle because a planner is dedicated to what he has to do, which is to plan. And the university, the academia, generates evidence in order to contribute towards making the necessary decisions. Unfortunately, in the case of our countries, I think that at least in countries like Peru, we have serious problems, since having oftentimes, again, the case of Peru, we have a space of interconnection, coordination, but we find ourselves at the time when we need to do proper planning, we don't have the necessary time or necessary resources. So we have to build better links and connections. Definitely the role to be played by generation and information, especially at operational levels, meaning doesn't suffice the generation of evidences or either review of data or information and generation of information, but the service themselves, when the role to be played is crucial, not only generation of evidence, but at the same time for the training capacity building of this professional, so that we can better articulate the competencies that are needed for the rendering of public health services. Thank you.
Thank you, Lizardo. Maureen?
So basically, in my opinion, closer collaboration between health and the educational institutions is of utmost importance in order for the development of training programs which actually address the needs of the market. So basically, one of the things we have actually realized is that if our university and if our colleges work in isolation, then they will not address the gaps, the needs we actually have as an employer. So basically, the university is our main supplier of healthcare professions. So if we do not have the supply which we actually need, or which we actually envisage we will need in the coming years, then it will obviously not be a successful implementation of our strategy. So working closer with the education institutions is of utmost importance. I would like to inform you that unfortunately I'm going to have to leave because I have been called to a very urgent meeting which I have to attend immediately. It has been an honor for me to be present today, and a very pleasant experience. Hope you have a good day. Thank you so much.
Obrigado, Maureen. Obrigado.
Thank you, Maureen.
Thank you.
Thank you for your participation in this space.
Thank you. It's been a pleasure. Thank you.
Bom, vamos aqui então seguir. A gente tem
Okay,
aqui...
let's move forward. We have 3 people here that, I'm sorry, 4 people that raised their hands. We have Mario, Diana, Cleide, and Cristiane, and we have a few questions in the chat room. So what I'm going to suggest is that we are going to ask questions to also contemplate people who are subscribed here and people who are in the chat room. So let's begin with Professor Mario. Good morning, Mario. Good morning, Bruno. Good morning, colleagues. Just very quickly, my experience, the planning experience in human resources and health is very concentrated on the national and local levels. In Brazil, we have a very diverse situation in the states. And when we think about to decrease the inequalities of human resources, the national policies not always are going to contemplate that. They try to be egalitarian, but I would like to understand the experience from our colleagues about your experiences or any other kind of reflection that you might have about like regional policies, differentiated regional policies. Of course, we talk about the states being articulated with other areas, but how could they be more effective, especially on the long run? So we have a lot of literature about Latin America and Brazil about the short term and the success of those policies. So how would you see the incentive policies, financial and non-financial, developed nationally, where the planning could be more efficient, and if maybe we could have more success? The studies shows us that the inequalities are higher in Brazil, in China, in India. We can see that we have more inequalities inside these regions. So this is what I wanted to say, to understand the experience of our colleagues here. Thank you so much. Thank you, Mario, for your contribution. I'm going to pass to Diana Bonfim. Good morning, everyone. I would like to thank all the experiences that were shared. I think it was a very rich morning in terms of learning. I'm Diana Bonfim. I'm a nurse. I studied my master's and doctorate degrees with Dr. Raquel. And we can see now, through these 10 years, we've been discussing and producing evidence. And I'm going to support this process, this planning process, in a more structured way. And recently, I would like to share, we've been meeting as a research group and interested in this subject to have a network, which is called the Dimensiona Network, when we talk about the health force here in Brazil. And we want to have discussions and dialogues to produce evidence for different spheres, not only when we talk about in the micro, meso, and macro level, so we can integrate knowledges, parameters, and also have subsidies and data analysis to be able to subsidize the decision making, which is not easy and it is not simple through time. So I would like to hear from our colleagues regarding the methodologies. We know a few methodologies that are available through the WHO. We have the indicators of staff needs that is used in different countries around the world that shows us evidence that are using already and showing the impact that we have in the micro and macro evidences in the countries. I would like to hear from people in the other countries if they have any kind of experience with the two or with another one. Thank you so much for this space. Thank you, Diana. So let's move on to Cristiane Ghosh. Good morning, everyone. My internet signal is a little bit unstable. I'm sorry if I freeze. Bear with me. So congratulations to Professor Carmen with the possibility of this discussion and all the speakers today. My question has a lot to do with Professor Maziali and also Professor Mario about the challenges and struggles that you can see regarding the information system that we have available to support the planning strategies and the experiences that were already presented. And how do you see the capacity building, the national capacity building in terms of planning? Thank you so much. Thank you, Chris. Since we only have one person, which is Clady, Clady, ask your question, and then we are going to move forward so we can have all the answers. Clady, please. Yeah, good morning. I'm really happy to be here today. This is such an important table and meeting. It is very provocative because we know that the tip of the iceberg, we can only see the tip of the iceberg. But when we talk about the workforce, it doesn't matter the region around the world, I think is fundamental. I am a teacher here at the nursing school of the University of Minas Gerais. And I have been working for many years in the Brazilian associations of OBGYN. And from those two places I've been working with capacity building and training of nurses around Brazil. And we are still working with this capacity building process. The first thing I would like to hear from you in this very necessary group to understand the international commitments because it involves kids and women, how the workforce is being thought. What are your experiences about planning of that workforce, the planning on how to plan that workforce in spaces where we have women dying daily because of poverty, because of territories, because they don't have access to health services? This is one question. And the other one is that through all these years of teaching uh, to nurses, we have been working with different uh, tools in those teaching processes and learning processes and capacity building. I think these are experiences that could be able to be accessible to everyone because we would like to feel more represented. I would like to know if is there some kind of planning, if you have experience of these repositories, and also along with what Mario said about planning, I would like to say also how can we think about respective aspects on monitoring and assessment of specific workforces beyond the necessary teams that we have on the Brazilian health system, and also thinking about the primary care for women and kids. Thank you so much. Thank you, Cleide. So I'm going to pass the floor to the speakers. I also have 2 or 3 questions in the chat room. Let me take a look here to see if they are similar questions, because it would be redundant. But no, I think in general, there is one question here talking about what are the struggles to retain the healthcare professionals in their own countries. I guess we already answered that. Another question is, do you think it's feasible in the future to have a managing data network of those health professionals that are going to integrate governments, hospitals? And I think it has to do a lot with what Cleide just asked about the information. And I think you can also talk about this. And there's another question here. Which do you think is the most challenge for the workforce in your countries? Already we talked about this. And also there's a question about migration of developed countries like Europe and the US, because this is a fact of many workers that went to countries that are not from Latin America. Please talk a little bit about that. And also, let's talk about data sharing amongst unions and councils. And Isabel Ture is asking us here. She's asking about if we have multi-jobs or different jobs in your countries, and how do you see the planning considering this question? So I think in general, these are the questions that people asked here so that we can answer them. Now I'm going to pass the floor to Lizardo or Beth, and please make your comments about all the questions that people asked here by our audience that's here in our webinar.
Não, pode ele responder, depois eu
No,
complemento.
please feel free to answer. Thank you, Professor Lizario.
Ok, gracias a usted. A ver, sí, son
Okay.
muy variados.
They're very variable and different, and I have understood 4 or 5 types of questions, right? So at the beginning, greeting to Mario del Por, Sarti, that very well known, and always supporting us in Peru whenever we need it. And also the question, the central question is exactly how this discussion that has been asked by Bruno, also in the sense of how do we have a relation between the international and national policies and subnational policies, where sometimes we have to standardize the processes when we have specificities that many times cannot be considered or cannot be understood or from a national level. So he used to ask if we have any kind of experience in this sense. And my presentation, part of the reform of this program was decentralization, exactly because during decades, 2 or 3, more than 2 decades, the planning of the distribution of all this personnel was centralized. It was from the health ministry. In 2007, we reached an agreement with subnational governments to embed variables that have been proposed by the health ministry and that have been also confirmed by regions in order to be distribution criteria and boosting specificities of each region. And where we distributed this personnel, this fact was really locally considered in order to optimize the recruitment capacity and retention of human resources due to the other subnational approach. So the main issue is that in our case, we don't have a continuity in the process. We have, in very few years, we have now, last night, for example, the health minister, we have had 11 health ministers in a short period. It's impossible to give a continuity in any area. So the second question, effectively, globally speaking, and regarding methodologies, we have used a lot of standardization of methodologies and processes to identify the quantitative gaps. That is one of the gaps that we have. The number of human resources, for example, is a standard that although it doesn't go to the detail of service rendering, it can also be a deciding policy for the governments, and this decision-making many times is done blindly without any kind of evidence. So this can really improve the detentions in order to prove that we have a critical number under which it is impossible to reach compliance in the coverage in specific territory. However, when we go beyond what, for example, has been mentioned here, the details in smaller territories, when we require not only the specific indicators, also the degree of productivity that is necessary for the users and the workers and the members of the teams. But this is one list that is quite advanced now, but it requires more details. But I draw your attention that on the other components of this management of human resources, strategically speaking, there's very little or no information why the residents take 3-4 years in some countries. So within your own country, there's no evidence that could tell me regarding an importance, for example, to specify that this is the number, which is an indicator that could standardize everything in order to know that a team is averagely capacity built and competent, for example, to implement FPS. That is a very complex problem. So this is a very rich subject for us to talk about in order to generate standards, in order to have the evidence, in order to have a better decision making. Regarding the subject of capacities that we have in our countries, in order to plan with a strategic look in the field, it is very scarce and very relative to say that in our countries, generally, there's no planification or the bureaucratic and managerial planning to have a document that has a title plan. We don't have planning processes that would incorporate the prospective look in order to reach, let's say, the calculation of what is necessary in the next 20, 30 years. Now, this process should be generating, let's say, the contact with academia, with the capacity builders, in order to expect no lack of professionals in the future. The pandemic that hit everybody, globally speaking, and has shown effectively that the ones that haven't worked in the last 10 years, we weren't able to solve everything during the 2 years of the pandemic. So we still do have in our countries, in the case of Peru, there is a lot of lack of capacities and competencies to embed a strategic look, a prospective look into the planning of human resources. Regarding this interesting idea of building a network of evidence generators. I think it's very important. Here in Peru, we started in 2005, the information of facts, let's say, complying the role that wasn't ours regarding the Ministry of Health. And information on human resources have brought a lot of publications of interest that are available. Let's say it's surely each of us is interested in this. Very interesting to have this exchange among knowledge providers. And regarding jobs, it's a great problem we all have in our country. And it's this black box that we don't have any kind of information. There are a lot of jobs, but they're not registered in order to have a decision making. During the pandemic, it has been very, very specific element because, for example, the health workers were the first ones to be vaccinated. And in the past, it was impossible to have a registry of all the people that were in different fields. They were doubling or triplicating their work. But because of all of them had to be vaccinated, we generated a universal registry of all the workers that is pending of the system registry, unfortunately, in our country at least. So evidently, this is still a pending matter in our case. And there's a lot of this that doesn't allow the planning of the availability of human resources in our health establishment. Thank you very much.
Betty.
Beth, would you like to say something? I think Professor Lizardo has brought us the most salient issues in relation to the practice, what's happening in public policies vis-a-vis planning and the workforce workforce in other countries. I'd just like to bring a question to your attention. Chris told us about the information systems that we need, in fact. We have many obstacles to overcome. We have systems with so much information compiled at the municipalities and the small towns and states and provinces. It's a great deal of information that we need to be able to reorder and organize the information so that it will cater to the needs in real time, in due time, and briefly and succinctly. And we need information that's close to the reality and the wishes and the construction and strengthening of public policies. That's what I have to say. Thank you so much, Bruno. Thank you, Beth. Thank you, Lizardo. Well, in addition to some questions we have here also, people congratulating you on the importance of this forum. This morning, we had a venue to exchange ideas and experiences that were brought to us by the people that are cooperating, the speakers, talking about this issue of having a process of following up on longitudinally following up on the performance of professionals, thinking of the implementation of these planning and dimensioning methodologies for the workforce so that we will bolster the supply of human resources. They all said that these contributions are important and strategic to serve as input for the decision-making processes of governments.
Que a gente possa qualificar o sistema de saúde.
And strategic processes so we may increase the quality of the work we do across the territory. We have some contributions, Jacine, Elizabeth Pais, and some people that wrote some comments. Actually, they're not questions really, they're comments, but they're important contributions to cooperate with this webinar, this roundtable. To wrap up, and I'll give the floor now to Carla. I'd like to say that it was a pleasure being here with you in this process of listening to you and all the experiences shared with us. We're only going to be able to strengthen and consolidate strategies to plan our workforce in the health arena, insofar as we're able to look at the successful experience and good practices, and also to look at the experiences that were not so successful, because lessons learned are always possible in any kind of experience. But above all, this exchange favors a new look at reality in the context of different countries. And based on that, we can actually look at our context and think, what are the possible strategies to be implemented in an area and on the ground, really? I think that the planning of the workforce is a very important topic, because health systems are staffed by people, by individuals. These are not just figures. We cannot do planning considering only the number of people, but we have to take into account their subjectivities, the needs of the people, the workers, and installed capacities, and above all, the epidemiological profile and the needs of the population. So we will implement sustainable networks on the ground in all the countries. I think that that is the big challenge ahead. I think we're only going to be able to do that if we work jointly, collectively, in a shared way, sharing all the information. I'd like to thank again the World Health Organization, USP, the Federal University of Sao Paulo, the institutions that are involved in this process, the nursery school, because we have the possibility of exchanging information and articulating our activities so that we may mature this discussion process on such important topics related to the management of the workforce and the health services arena. I'd like to wrap up my participation, thanking all of you. And I'm going to give the floor now to Carla and Julia for their final considerations. Thank you. Thank you, Bruno, for your excellent moderation of this debate. We've had a great deal of information and topics to be discussed. And now, in closing, I'd like to give the floor to Monica Durans from the World Health Organization. Good morning, all. It's been a pleasure being with you. I'd like to wrap up before giving the floor now to Julia. I'd like to thank you for your participation. I am at a place with a low internet connectivity, but I'd like to thank you for your cooperation, the whole team and our speakers for their availability, and everyone who's here with us. And I do hope that we'll forge ahead and do further work in the future. We have representatives of COPIN, Bing, SAP is the Ministry of Health, CONASI. I think that this is a great effort, a joint effort by all of us. And I'm so glad to see everyone here sharing these experiences. I'm going to give the floor now to Dr. Julie Pedrosa, our coordinator of health services, so we can wrap up our webinar before Professor Carla. Thank you so much. I do wish, I would like to thank the whole team of the ministry, Dr. Bruno, and also Monica. Monica has been working strenuously. This webinar, I hope it will be the culmination of a long process. As some of you know, I worked as the coordinator in May as a coordinator, and I was surprised by the intensity of the work that you do, and with a view to improving the conditions of health workers and the improvement of healthcare for the population. I'd like to congratulate also the countries that have made presentations, especially my friend and colleague, Dr. Gustavo Gaman. I worked with the Ministry of Health with Dr. Gaman for many years, and we studied at the same university in Lima, Peru, San Fernando, San Marcos. Thank you, Dr. Lizardo. we will be in contact. We'll be in touch. Thank you so much. Good morning, all, and congratulations. Thank you so much, Dr. Julia and Monica. I'd like to thank, on behalf of the whole team, to all the members of the work group. The status of nursing in Brazil, this webinar was a rich possibility for us to share
E do Brasil, e também
share and get to know experiences in Malta, Peru, and Brazil, and to discuss the possibilities for action related to accessibility and availability and the challenges ahead. This event represents an important juncture to strengthen this work group and also to build ties to other partners to do research and act on this particular topic. Therefore, our expectation is to keep working that emphasizing this dialogue towards better planning the workforce and the health services domain. I'd like to thank Dr. Lizardo, Dr. Marina, and the speakers and the staff and everybody who's with us in this building process, especially the Ministry of Health and the Pan American Health Organization for their trust and cooperation. I'd like to also thank Ana Paula and our researchers and on this project. They've been working with us since 2021. We're wrapping up this activity and we're motivated, I'm sure, to keep working on this collective and joint effort and to make a difference when it comes to the workforce and health and the health services of our country. Thank you our countries. Thank you so much and good afternoon, everyone. I'll see you next time, hopefully. Thank you very much. Good afternoon, everyone. Bye-bye. Good afternoon.
Encerrado no YouTube. Carla, está encerrado no YouTube?
Então,
Cleomar?
Ana Paula, está encerrado? Deixa eu perguntar aqui.